not what is written there, what is left behind, what is in between the line, reading between the line is the one which helps you to understand the strength, weakness. Just don't go by what that author writes and see the conclusion. Use your brain, take help of your mentors and teacher, try to interpret yourself the strength, weakness, real practical application. To interpret that, a student would need a teacher and a mentor to show guidance path. And that is why we have two very good head and neck surgical oncologist, Dr. Devendra, whom all of you know, is a teacher for teacher, a great contributor in our IASO, and an excellent, outstanding head and neck surgical oncologist in India. And he has served a long time as a professor in Tata, and he has taken many, many classes for us, and also extremely active in IASO and various academic. And then we have Dr. Girish Shetkar, he is a head and neck surgical oncologist from Aster International Institute of Onco, and we have a great student who is ready to go into the fight like Abhimanyu, and that is Dr. Rakesh, who is from Mahavir Cancer Samstha, Patna. So we have two good paper being selected today, which will be presented. Please ask your doubts, question pertaining to this in the chat box, and both the experts will try to answer in the given time. Thank you, Devendra and Girish, for accepting invitation in spite of a busy schedule, doing great work, help for the students and national board. And welcome, and over to you, Rakesh.
Thank you, sir. Good morning, my respected teachers, my seniors, colleagues, and juniors. So today we are going to discuss two recent articles from the well-known journals. So first is the phase 3 RCT comparing docetaxel platinum with docetaxel platinum 5-fluorouracil as neoadjuvant chemotherapy in borderline resectable oral cancers, published in European Journal of Cancer in January 2014. And this study was done at Department of Medical Oncology, Tata Medical Center, in the guidance of Vanita Norona ma'am, and Dr. Devendra Chokar sir was also part of the this article. So background. Oral cancer is one of the commonest malignancies arising in the head and neck region in Indian subcontinent. And most patients of oral squamous cell cancers are in India present in the locally advanced stage, that is in the tune of 90%. So the definition of resectability in oral cancers is subjective. Resectability depends upon the extent of disease, invasion, attainability of clear margins, and ability to perform a functional resection and reconstruction, thus minimizing the loss of function as per this article. So it gave a lot of confusion between different institutes and different practitioners, like which one were to consider in which group. So this was solved. As we can see, there is lack of clear dichotomy in the matter of resectability has given rise to gray area, widely termed as borderline resectable. And this was solved by Dr. V.M. Patil sir et al. Study, which was a detailed objective anatomical landmarks, and they sought detailed anatomical objective landmarks, and which, if involved, would make clear margins unattainable or would lead to morbid resections. So in brief, we can see that this was an article published in October 2014 in Oral Oncology, and the criteria were as following. The management of all patients was done as per discussion in the MDT. So borderline resectable cases were buccal mucosa primary with diffuse margin and peritumoral edema going up to or above the level of zygomatic arch without any satellite nodules. Tongue primary anterior to third with the tumor extending up to or below the level of hyoid bone. Extension of tumor of anterior two-third of oral tongue to the vallecula. Extension of tumor into the high ITF fossa. High ITF as defined by the extension of tumor above an axial plane passing at the level of sigmoid nodes. Extensive skin infiltration impacting the achievement of negative margin. So these all were the criteria. So it objectified the whole criteria, and inter-institution or inter-practitioner comparison and results, seeing the results became easy. So treatment of borderline resectable oral cancer is a challenge, and the outcomes with morbid surgery are grim. And in definitive chemoradiotherapy groups, there were survivals less than 6 months in most of studies. So the use of induction chemotherapy came in the picture, and with the goal of making the tumor resectable with a clear margin as a standard treatment approach in India. And these are the reference articles. There have been many, including by Dr. V.M. Patil sir et al. And many articles related to it in India by Dr. Devendra Chokar sir also. So all of these summarized in summary, they showed that two-drug chemotherapy being most common agents used being docetaxel and platins, they showed cumulative resectability rate of around 25 to 40%, and three drugs, that is TPF regimen, it resulted in tune of 45 to 70% resectability rate, and on average both the regimens, that is induction chemotherapy, resulted in 35 to 45 resectability rate among these locally advanced cases. And the median overall survival, which usually was less than 6 months, improved as high as 15 to 20 months on an average. So the major challenge in most of the studies was the three drug regimen resulted in higher toxicity rates. So there were less patients who can receive three drug regimens. So let's see further. Neoadjuvant chemotherapy regimens consisting of 2 or 3 drugs are used, and the 3 drugs regimen of TPF, that is docetaxel, cisplatin or carboplatin, and 5-fluorouracil is considered the standard. 2 drug regimen options consist of platinum, cisplatin, carboplatin, and ataxin or 5-fluorouracil. So about the chemotherapy and in use in different case scenarios, this is a good article. We can see some highlights of it. So neoadjuvant chemotherapy in oral cancer, current status and future possibilities. It was published in October 2019, and from it we can see the summary that there is a limited role of NACT in resectable oral cancer and should not be used outside of a well-designed clinical trial. Patients with technical unresectable oral cavity cancers may have response to the tune of 70% with aggressive 3-drug regimen, and a third of these patients may benefit from the subsequent surgical treatment. So this trial also concluded that emergent need to generate Indian data from prospective randomized trials to substantiate the benefit of induction chemotherapy in resectable and technically unresectable oral squamous cell carcinomas. So this was the research question for this article. The true drug regimen of docetaxel platinum has shown promising results in locally advanced head and neck squamous cell carcinoma and is preferred in community practice. But it was never compared in a prospective randomized study to TPF. Hence, this trial was planned with primary objective of comparing the overall survival between the 3-drug and 2-drug regimen, 3-drug regimen being TPF and 2-drug regimen being TP regimen. So methods, this was a phase 3 randomized parallel arm open label superiority design and single center study. And the criteria, as we discussed already, were these criteria. Plus there was one other criteria, disease encasing the carotid 180 degree to 270 degree. The TPF regimen was administered inpatient and consisted of docetaxel at dose of 75 mg per meter square, administered on day 1 as 1 hour infusion, followed by cisplatin at dose of 75 mg per meter square, given in the same fashion, and 5-fluorouracil at dose of 750 mg per meter square per day, administered as a continuous infusion on day 1 to 5. So this infusion, continuous infusion, results in logistic and inpatient admission for this. Otherwise, if the 2-drug regimen is there, it is a day care procedure. So if cisplatin was replaced by carboplatin, then a dose of area under curve 5 was used and administered as 1 hour infusion on day 1. Patients were evaluated after 2 cycles of chemotherapy with axial imaging in accordance with RECIST 1.1. Based on the response and performance status, further treatment, either surgery followed by adjuvant or radical chemoradiation or palliative therapy was planned. The window for undergoing surgery post NACT was 3 to 8 weeks. Adjuvant chemoradiation was offered to all patients irrespective of post-operative histopathology. So in brief, we will see what is RECIST 1.1 and how it is evaluated. So this is the baseline disease, that is, it is indicated 100%. If we give chemo and the complete disappearance of tumor is there, it will be known as complete response. If the response is more than 30%, but it is not complete disappearance, it will be partial response. If there is less than 30% response or there is increase in the disease more than up to 20%, it will be stable disease. And if there is more than 20% increase, it will be progressive disease. So these were the statistical methods used in this study. It was intention to treat analysis. So we will discuss about the results. These are baseline demographic details used in the study. So as we can see that the age more than 60 years were more in the 3-drug regimen. And it was also statistically significant. And rest other were distributed well. So, and again, we can see that the T4B group patients were more in the 2-drug regimen. And N3 patient and the stage 4B patients were also more because T4B were more already in 2 drugs. So it resulted in T4B also. And these are this is the Kaplan-Meier survival curve for the overall survival. Here we can see that at 1 year there was statistically significant difference in the both drugs, TPF arm being superior. So the median overall survival was 10.3 months and 12 months respectively in the 2 and 3 drug regimen, and it was statistically significant. The 5-year overall survival was 18.5% in 2 drug and 23.9% in the 3 drug regimen. So here we can see the overall survival in different categories. So as like on brief, we can see that 3-drug regimen is almost superior in every scenario. Here we can see that in this group it is statistically significant in the males, though it doesn't affect that much. But in the ECOG 1-2 group also it is statistically significant, and in T4B group also it is significant. In N2 and 3-drug regimen is giving more overall survival, and for in the primaries buccal mucosa are doing great with the 3-drug regimen. And here we can see that how does the pathological complete response affects the survival. So in this study it was concluded that the patients receiving attaining pathological complete response were having more overall survival benefits, and pathological complete response was noted in 22 patients, that was 13%. The number of patients with a pathological complete response was higher in the 2-drug regimen, though it was 13 patients in TP regimen and 9 in the TPF arm, but it was not statistically significant. The major concern, as we have already discussed for 3-drug regimen, was the adverse events. So here we can see in this table that mucositis, febrile neutropenia, hyponatremia, hypokalemia, anemia, neutropenia, all these, though they are more common in the 3-drug regimen, that statistically significant. Grade 3 or above adverse events were seen in 39% in 2-drug, while 72% in the 3-drug regimen, but they were managed well. So we will see the compliance. As we can see that in 2-drug regimen, patients allocated were 248, and in 3-drug regimen, they were 247. So in 2-drug regimen, completed cycles were in 227 patients. Reasons for non-completion were progression in 8 patients, adverse events in 6, and patient preference in 2 patients. To compare 3-drug regimen, 217 patients completed, that is roughly 88%. It is a huge number considering the 3-drug regimen receiving completion of the 2 cycles. And reason for non-completion were progression in 6, adverse events in 8, patient preference 4, and deterioration of the performance status. So here we can see that the dose reduction in platinum was required in 1 patient in TPM and 12%, that is 5% in the TPF arm. The dose reduction was needed, but the patients completed with that. Dose reduction in docetaxel was required in 1.2% in 2-drug and 13, that is 5.5% in TPF arm. These all were statistically significant. In the TPF arm, dose reduction in 5-fluorouracil was required in the 28.8%. So more than 2 cycles of chemotherapy were received by 83 patients in 2-drug regimen, that is 33%, and 41.3 in the TPF arm. So post-NACT, what was the outcome? What was the different treatment options given? So first is post-NACT surgery. Post-NACT, the disease was deemed to be resectable in 43.8% and 34.5% underwent surgery. So 84 in the TP and 87 in the TPF arm were resectable, and they received surgery. The median time for commencement of chemotherapy to surgery was 73.5 days in 2-drug and 85 days in 3-drug regimen. R0 resection was performed in 97.6% in the 2-drug and 100% in the 3-drug regimen who underwent surgery. 5-year overall survival of patients who had surgical resection versus those who did not were 50.7% and 5%. So there is huge difference after giving the chemotherapy, and it was statistically significant. The 5-year overall survival in the patients whose disease had become resectable and underwent resection versus who refused for surgery was also showing wide margin of overall survival. Like it was 50.7% who underwent surgery, but only 12.5% who refused for surgery. The 5-year overall survival in patients who underwent surgery in the 2-TP and the TPF arm was 47.2% and 55.2%. So 3-drug regimen was showing superior results, but though it was not statistically significant. The 5-year overall survival in patients who had pathological complete response versus those who did not was 90.7 versus 43.6. It was statistically significant. So then what was the results of patients receiving definitive chemoradiotherapy after NSCT? So median overall survival in patients undergoing definitive chemoradiation was 11.2 months and 8.1 months. 5-year overall survival was 8.1%. The median overall survival in the TP and TPF arms were 8.6 and 14.4 months respectively. So compared to surgery, this is lesser. 5-year overall survival was 0% and 11.2 compared in 2-drug and 3-drug regimens. So what were the results? Patient receiving palliative therapies, the median overall survival treated with palliative intent was 7.8 months. The median overall survival in the TP and TPF arms were 7.5 and 8 months respectively. The median overall survival in patients receiving palliative radiation, palliative chemotherapy, and best supportive care all were in range of 7.7 to 7.8 months. Then key extracts from this article: TPF regimen resulted in 5.4% absolute improvement in the overall survival, 23.8 proportional increment in the overall survival over TP. Although the adverse events with TPF were higher than the TP, they were managed well, and much lower mortality was seen in the contemporary comparative series. The resectability rate, that is the proportion of patients deemed to have resectable after NSCT, was 43.8%. However, only 34.5 underwent surgery. The outcome of the patients who underwent surgery as opposed to those who did not was subsequently different, as we discussed already. Oral cavity cancers and higher stage tumors have a lower response rate than lower stage tumors. Surgery performed was in accordance with the post-NSCT tumor volumes, and adjuvant chemoradiation was contemplated as additional treatment. This was also a big question, that what should be the margin after post-NSCT. So this has been also clarified in this article, that we can take post-NSCT tumor volumes as margins. And adjuvant chemoradiation post-NSCT is a challenge in terms of tolerance, but it was well tolerated in this article. So limitations of the study were it was a single tertiary cancer treatment care academic center study. Imbalance in age and stage grouping were there, but on multivariate analysis, they hardly make any difference in the results. And indication for NSCT, more patients with a functional indication in the TPF arm, some differences in the therapy, but it doesn't affect the results as much. The study used cisplatin 30 milligram per meter square as radiosensitizers. Most of the other studies used 100 milligram per meter squares because they showed that lesser dose is associated with less overall survival. But this was not true in this study. There was no difference in the overall survival. So conclusion is TPF chemotherapy regimen as NSCT improves the progression-free survival and overall survival in comparison to the TP regimen in borderline resectable oral cancers. Thank you.
Thank you, Rakesh. Very well presented. You dissected the paper very well.
Thank you, sir.
Whenever you read the paper, as Dr. Somashekar said, that it's not what's written in the paper. It's you need to understand why this paper has been produced. So give me a little bit of a background as to why you need such a trial. Why is this paper come out? Why do you need to compare TPF with docetaxel and cisplatin?
So, sir, the whole in cancer treatment, as we need is the overall survival or benefit we are giving to the cancer patients. So, in this group, first there was confusion about which patient we should consider in borderline resectable or which not, which was cleared by the Dr. V.M. Patil sir and et al. Article, and it was also a comparison retrospective analysis of 3 drug versus.
Interrupt you here.
Yes, sir.
Are there any articles to the contrary saying that NACT is not the way to go for, and there is no such thing as borderline operable? There is either operable or inoperable. Is there a group which has published such results?
Sir, I'm not aware of any such study, sir.
Okay. So all of you must know that in head and neck cancer, there's a group which is operable cancer, which he defined very well, ability to get negative margins and a functional reconstruction possible. And there's inoperable, carotid involvement more than 280 degrees, skull base involvement, prevertebral fascia involvement. There are certain criteria. Borderline operable is where the surgeon feels they cannot get margin, and there are Dr. Nirav Trivedi and the Amrita group have produced papers where they resect these patients with large resections, and I've shown good survival. They're classified into 3 classes. So please read that paper by Nirav Trivedi and this. So you'll have a contrary view to NACT. NACT is not standard of care, right?
Okay.
So there is a contrary view to NACT saying that no, we need to resect because there is either operable or inoperable in oral cancer. Okay. Now, having said that, what we found at Tata was that some patients were we were unsure whether we'll get negative margins, hence gave the patients NACT. Now, what is the standard dose? What is the standard regimen of NACT, and why is that a standard regimen?
So 3-drug regimen is considered standard, but in community the 2-drug
considered standard.
Yes, sir.
Who told you 3-drug regimen is considered standard? What are the trials?
Sir, like the retrospectives, like as per the study results, like from Dr. V.M. Patil sir and all.
Not
these.
What was the drug that was given before docetaxel? This 3-drug is docetaxel or platinum, platinum, taxane, and 5-FU, correct?
Yes, sir.
What was the drug used in the initial trials of NACT?
So docetaxel was added later, sir.
Because we're short of time, quickly there's an answer in the chat box, and very correctly said, the first initially they used 2 drugs, cisplatin 5-FU, and then give the tax 323, 324 papers. Again, read those papers for NACT, which said that these papers are better. 3-drug regime is better in overall survival and outcomes over the cisplatin 5-FU. Okay, so that was the basis that now the 3-drug is better. Now they said that okay, if 3-drug is better, that means taxanes are adding something, but the toxicity is higher. Why not compare it instead of 5-FU, which is given over 5 days, causes a lot of toxicity, patient needs to be admitted. Why not replace that with taxane? So that is the basis why they have compared docetaxel cisplatin 5-FU with taxane and cisplatin, not cisplatin 5-FU. Understood? Everybody understood that? Okay, so that's the basis. You go ahead and do the study. Girish, you want to ask any questions about the study? And Dr. Somsekhar. Girish, please go ahead. Girish, you're muted. Yeah.
Sorry. So I was just, the concerns that as a surgeon one would have is about, your margins post NACT. So although, in Chauker's earlier paper about, doing, when you have to decide between doing a segment mandibulectomy versus doing a lesser sort of a thing, where it's shown that you can actually take the post NACT margins, but just that, tumors where, you don't expect them to concentrically, shrink. So that is one concern that one would have, as when we have to treat them surgically post NACT. So I think we need much more studies for us to sort of, move to such a practice where we take post NACT margins. So that is one thing we will have to look at. Yeah.
So Rakesh answered that, and that question has come into chat box also. If in the exam, if they ask you, what are your post NACT margins? How would you answer this question?
So, sir, post NACT volume can be taken as a margin from as backed by this study also.
How wide will you go? Will you go 1 centimeter, 1.5 centimeter? Volume you will get. Volume is the tumor.
Yes, sir. So
How
1
wide
point,
will you go? Whether you'll go to pre-chemo margins, then it makes no sense of giving NACT, right? If you're
yes,
going
sir.
to go to the pre-NACT margins, or
Yes.
will you just go a little wider? What will you base? How will you answer this question in your exams?
Sir, in my knowledge, 1.5 centimeters post NACT as per the post NACT status.
So Rakesh, really, this is a question which most of us won't be able to answer. There's no right answer to this. But the way you answer this question is right from Lysitra's trial to Zong's trial. If you look at the outcomes, they were not inferior in the NACT arm. Okay,
Yes.
they were not superior. They were not superior, but they were inferior to the surgical arm. That means whatever, and the margin positivity rate was not higher neither in the Lysitra trial, nor the Zong trial, nor in our mandible preservation trial. And we went as per new margins, we did conservation. So the margin positivity rate was not higher. Yes, there is a chance, as Girish said, they don't concentrically shrink, and there may be islands of tumor cells, but probably because of the adjuvant therapy of chemoradiation or radiation, these islands of tumor cells are being taken care of. Hence, your answer will be that I will not remember or I will not know the pre-NACT margins unless I've tattooed them. So I will go a little wider than what I normally take, trying to encompass the entire tumor. There's no right answer to this, but going by the current publications, going by the NACT studies, the incidence of positive margins is not anywhere higher than upfront surgery. Okay, so it's the answer is not clear, but you have to answer it this way: looking at quoting the trials, quoting that they don't have increased margins, and you will go a little wider than what would you normally go in a upfront or a virgin tumor. Okay, that's how you'll answer this question,
Okay,
right?
sir. Okay.
Right. So now we have some few more minutes. Which is a better trial? Is this trial good, or you want to do a better trial? What would be a better trial design, according to you? Do you want to compare any three drug versus two drug, one drug? Somebody has said we can add immunotherapy. Yes, of course we can add immunotherapy, but this is just playing around with the drugs. What is the real question that we have not answered? Okay, Rakesh, we don't have time, so let us
Okay.
just. So NACT has not shown superiority over upfront surgery, correct? The Zong trial, Lysitra trial, everything are negative. So we don't give NACT for operable cancers.
Yes, sir.
But if you look at the Zong long-term analysis, there is a slight benefit or tend towards benefit in larger tumors and tumors which are N2. Okay, so large tumors and N2. So now is the time to probably look at NIRV study and look at the NACT study and do a study for large tumors. In operable cancers, we know that NACT doesn't work. But when the tumor burden is higher, when your failure rates are higher, okay, with N2 disease, T4 large skin involvements, that is probably an area where you should have said that I would do a trial of upfront surgery and NACT. That would be a better trial than to compare three drug versus two drug. Okay. Why have they done this trial then? Why have they compared three drug versus two drug when we know by tax 32324 that three drug regime is better?
So in 3 drug regimen, there were logistic issues and inpatient admissions were needed more, sir.
So it's logistically very difficult. It's very toxic to give three drug and cannot be given across pan India. So we are looking at better modalities. Immunotherapy may be such modality in the future to decrease the toxicity while keeping the rate up. Yeah. Girish, any question from you?
No, sir, should be okay.
Right. Girish, should we finish this article? Some chat box. We'll take some questions in the chat box. Or,
yes. Yeah.
right.
Should we take relating to the previous paper and then proceed, or should we
This
take
paper
all the
will,
questions?
the current paper that we have discussed, we'll take it. So we'll move on to the next paper and finish it instead of
Sure.
going back and forth.
Yeah.
Right. So there are questions. Post NACT margins we've discussed. Tax 324 is the answer. Some people have given very good. T4B versus T4A. So an NACT in T4B versus T4A. So the question here is which subsite or which subset of patients respond best to NACT? Rakesh.
Sir, as we already see the criteria for borderline resectables. So in among these also T4 as is also shown in study that high height conversion and high ITF to like supranodes to the infranodes becoming the disease operable is not seen that much in the NACT studies. So I think as also shown in this group that the tumors involving the masticator space but not going in the supranodes region can be the best fits for this, or the tongue cases which are involving
So that's a correct answer. So subsites which respond best are tumors which go up to the zygoma or soft tissue disease or masticator space involvement. If you read, again, there's a paper on this. Please read that paper by Dr. Shiva and Dr. Sudhir Nair. There's a paper which looks at which which T4 cancers do better with NACT. And patients who have bony involvement or high IT or ITF involvement don't do that well. They do well with upfront surgery. Patients who have soft tissue disease, going up to zygoma, just masticator space involvement, do better with NACT. So these are probably the subsets of patients that do better with NACT. Girish, any other question that we have? Yes, soft tissue involvement, somebody has written, very good. That's right. Any other question? Girish, any other question
Yeah.
we're missing?
No, I think so. I think most of them are covered, I think.
Right.
Yeah.
Okay. So quickly we'll wrap up this NACT. So NACT, as Rakesh said, that is not a correct way to treat oral cancers. Surgery is the correct way. Only for patients whom you think that you are unable to get a margin. There's large tumor, multiple nodes. Is sometimes you can try the NACT route to shrink the tumor and try to get negative margins. The concept of mandibular preservation is still in the phase 3 trial. It's a good hypothesis generating trial that we did in phase 2, whether to give NACT, and we can do similar trials across the country for tongue cancer. Total glossectomies, we know that has a very dismal prognosis functionally and oncologically. Maybe in that we can try NACT, since we are getting better drugs which are less toxic and more response rates in these drugs. Okay, Girish, any closing statements for this?
No, I think was what Chaka sir also was telling, that there are quite a few of these T4Bs that we can consider upfront surgery, as we have also learned from previous papers, like treating it as a compartment when we have to treat them surgically. Like there are quite a few T4Bs, except the high T4Bs, that you can actually compare them with T4As. So understanding the concept, the technique that is involved in addressing these tumors surgically, I think we can give good results with upfront surgery, and following it up with, it goes without saying that adjuvant treatment is quite imperative when we treat these locally advanced tumors. And we have one thing we have note that these the buccal or the GB complex tumors don't tend to have the nodal burden, unlike some of the other subsites of tongue and floor of mouth. So that's again one small aspect which goes in favor of as much giving them the best chance by doing whatever radical surgery that you can do, and also functionally also taking care of reconstructing with appropriate reconstructive methods that one can consider.
Girish, there is one question by Soumyata Mishra, whether up to zygoma is T4A. Well, disease that comes out into the soft tissue up to zygoma will involve that masticator space, and they are now classified as T4B, right, Girish? So,
Yes, sir.
But that classification, that TNM has been challenged because our T4B, just because of masticator space involvement, they don't do that badly.
Yes.
So there are now data coming out that should not be classified as T4B but T4A. But currently that is T4B. Professor Somshekhar, if you're here, do you have any closing statements, or should we move on to the next?
No, I just wanted the students, to understand, because when we go as an examiner, both for MCH as well as to DNB, this question always is asked. They'll say, okay, now this paper showed DFS, OS, increase the resectability rate, and you stratify the patients into those who are PCR versus no PCR, because 90% versus 45%. But does it change for a surgeon? Because resectability, operability are two different issues. Students must understand, and it varies from institute to institute, to a person to person. You can practically remove the entire deglowing of the face, put a microvascular flap, it looks resectable. but balancing that quality of life, able to achieve negative margin in all the time by average institute with the right is very different. So this margin question, as Devendra told, is the most hot, even which we as an examiner between four of us are never able to solve. This question is always, see, like, I'll give an example. Breast conservative surgery in a advanced cancer by neoadjuvant, making it amenable for organ preservation. Rectal cancer close to sphincter with neoadjuvant chemotherapy, shrinking the margin, making it amenable to organ preservation. These issues, we take a margin, what is left after neoadjuvant treatment. It's very clear. Trials have shown that it's rather than the margin negativity, there is no impact in the DFS OS. But in head and neck, we are there yet not there. Like most of the head and neck surgeons know this borderline T4A and T4B is neoadjuvant is, but there is no like outright RCT which can show the margin, what is left behind after that can be taken. That is why this issue is there, and diplomatically, this is a point you must understand the way Devendra told to answer. Otherwise, rest past. And then finally, what you can do in this exam, I always recommend our students when four examiner two are aggressively, Acha, you want to take the margin. So no matter you give chemo or not, you're going to reset what is left behind. You make a statement, sir, this is the institute protocol in the place where I got trained, and take my word, it will never go wrong because most of your teachers are already a exemplary surgical oncologist and people know there is a reason they drew. So if finally you say, you can always say this was the institute protocol where I got trained. Thanks, Devendra.
Thank you, sir.
Just a small point.
With your permission, can we go on to the next?
Yeah, Shetkar, you wanted to make a point.
I just want to add this. In certain patients, especially with high T4B patients, giving NACT before surgery would also help you in sort of understanding the disease biology. So then, if they don't respond well, then whatever you do, they don't actually do well. So that's again, triaging your patients will also help in certain cases.
Excellent point,
There is
Girish.
one more. Yeah, there is one more argument. Always, students, you must remember. This went through in breast, went through in pancreas, neoadjuvant chemo in a patient where probably you could operate with extra surgery with extra microvascular flap. Is what is the percent of the patient who might progress and a curative surgery be denied to them? In breast, it is less than 3%, and in rectum, it is less than 7%. Pancreas, it is 21% as per the MD Anderson trial. And Devendra, you can probably add, looking because you have been part of so many excellent NACT trial. What would be the percent you would put? Rarely a patient might progress and may never end up with a surgery. Otherwise, would have been operable.
It's less than 5% the progression of in NACT, less than 5%. Because of the toxicity, they don't get surgery. So out of 64 patients in the NACT trial, only one patient had toxicity and could not get surgery, and one patient had progression. So it's less than 5% overall. So great point. Before we go to the next, great point made by Girish, and we forgot that. So when the examiner asks you, then what is the point in giving NACT? So you said there are two things, sir. One is shrinking the disease to try and get negative margins, and diplomatically you have to answer that. I'll go a little wider. And second is I'm going to triage these patients. Okay, I know these are a group of patients who are not going to do so well with upfront surgery. They're going to fail. So I want to pick up patients who are going to do well. I can prognosticate them. So this will tell me the biology of the disease, especially in a very high volume center where you are not going to waste time on a T4B going into high ITF. If that patient miraculously responds to NACT, this patient is going to do well. You're going to triage and take him into surgery quicker. And the progression rate is not that great. It's less than 5% in most of the trials. But please check it up in the ZOG, etc. I know my trial, so it was less than 5%. So that's another point that we missed out. And Girish, thank you. So let's go to the next paper because we are running out of time now. So you can start presenting the next paper.
Okay, sir. So the second article today we are discussing today is re-examining the predictors of pathological lymph node positivity in clinically node-negative oral cavity cancers. Article published in Oral Oncology in June 2023, and it was done at Department of Radiation Oncology and Surgery at the in United States. So introduction for the same. Elective lymph node dissection is part of the standard of care surgical treatment for the majority of the early stage oral cavity squamous cell carcinomas with clinically negative neck. As we all know, this is a landmark paper done by Dr. Anil De Cruz sir and team. So we will briefly see the insights. So it was elective versus therapeutic neck dissection in node negative oral cancers, and it was published in 2015. And these were all the baseline characteristics and the results. So overall survival was better in the elective surgery compared to the therapeutic surgery group, and at the 3 years, every 1 out of the 8 patients was having overall survival benefit, and disease-free survival was also better in the elective surgery compared to therapeutic surgery. At the end of 3 years, every 1 patient out of 4 patients was having benefit in terms of disease-free survival. So is it true for all early stage cancers? So the answer seems to be no, because the subgroup analysis of the same paper showed that patients with superficial tumors DOI 3 or less than 3 mm have very low risk of nodal metastasis and no survival benefit from the ELND subset analysis. The primary factor utilized to identify early stage oral cavity squamous cell cancer patients that do not require ELND is the DOI, as it has been also incorporated in the staging, primarily established in patients with oral tongue, and is less clear whether DOI remains a strong predictor among other oral cavity subsites or not. So the research question, if other pathological factors could be utilized to identify a subgroup of patients typically recommended to undergo neck dissection by DOI criteria with sufficiently low risk of nodal metastasis such that neck dissection could be avoided. So briefly, some patients early stage cancers, and authors evaluated the predictors of pathological lymph node positivity among patients with clinical N0 oral cavity squamous cell cancers more than superficial DOI, that is more than 2 mm, in a large 2 mm or more than 2 mm in a large national data set. So the aim and objectives, predictors of pathological lymph node positivity among patients with DOI more or equal to 2 mm, and build a nomogram to identify patients that could potentially avoid neck dissection if any subgroup existed. So it was a retrospective analysis and included the patients who were clinically node negative, underwent curative intent surgery with or without adjuvant treatment. Exclusion criteria were patients who received neoadjuvant treatment, had fewer than 10 lymph nodes retrieved with incomplete staging, treatment or follow-up data, patients with DOI less than 2 mm, and who were missing critical pathological factors. So statistical analysis, these were the different methods used, and these are the results. So first we see this is the factors affecting the node positivity in clinically N0 oral cavity squamous cell carcinoma. So here we can see that in the T2 to T4 subgroup, the multivariate odds ratio is 2.187, and it is also statistically significant. Likewise, we can also see in grade intermediate and high grade are having more odds ratio, and in the lymphovascular invasion, the odds ratio is 4.267, that it is the maximum among all. So it is affecting more in the oral cavity. The DOI group, we can see that even in the group 10 to 19 or more than 20 mm, it is not affecting that much in case of oral cavity cancer. And rest of other factors are not affecting the node positivity that much. So now there is comparison in the oral tongue, clinical N0 oral tongue. What are the factors affecting the pathological node positivity? Same way we can see that the higher stage tumors are having more odds ratio. Intermediate and high grade are having more odds ratio. Here we can also see that LVI, if LVI is positive, it is the strongest determinant. It is the most, it is having the maximum odds ratio. And depth of invasion, here we can see that if there is more than 20 mm, the odds ratio is in range of 2.012. That is, it is affecting, but though it is affecting in the tongue cases, the LVI is the major factor here also. Then what are the factors affecting node positivity in clinical N0 non-oral, non-tongue subsites? In the same way, we can see that the stage, the grade, intermediate high grade, and the LVI here also it is affecting. The DOI is not affecting at all here. So three factors come out of all these results. That first is the DOI, depth of invasion. Here we can see that this orange one is the tongue subsite. So DOI is as the DOI is increasing, it is affecting the tongue cancers more. So it is increasing the pathological node positivity rate correlated with the DOI in tongue subsite. Then the second is LVI. In LVI, we can see that all subsites, be it the tongue or other subsite, they all are affected. So means that if LVI is present, pathological node positivity is more. And in the grade, third is grade. In grade, we can see that if intermediate or high grade is there, then the likelihood to having pathological node positivity rate is more. So this was the nomogram built based on this study. Here we can see that the subsite we can know pre-op, T stage we can know by pre-op imaging clinical workup, grade we can also know by the biopsy. LVI is the one thing that is questionable because clinically before surgery it is hard to guess or assess the LVI. It is only shown in the pathological report. DOI and rest other margins we can get solved with the help of frozen section and all. So based on this nomogram, approximately 20% of patients in this cohort with DOI 2 or more than 2 mm were found to have 50% or less risk of pathological node positivity. And by a norm, as a thumb rule, we all know that if it is more than 20%, there becomes the indication for node dissection. So in this subgroup, we can omit the node dissection. Limitations, retrospective analysis, patient and disease-related factors were not identical. And to use the nomogram for clinical decision making, the neck dissection and primary tumor resection would need to be staged as separate procedures because the major affecting factor is LVI and that we only can assess through the HPR. Conclusions, the presence of LVI and high-grade tumors were the strongest predictors of pathological node positivity. DOI does not predict for pathological node positivity in clinical N0 oral cavity squamous cell carcinoma outside of the oral tongue. And a subset of patients could potentially benefit from consideration of omission of ELND. Thank you.
Thank you. Girish, you want to go first?
Yeah, so I think the assessing the depth of invasion, which we have already sort of so regularly discussed about, based on that we decide whether electively should we treat a neck in a N0 setting. But other than the tongue as a subsite, assessing in other subsites of oral cavity, it's always a challenging thing. That's one thing. And then knowing upfront, when you do a biopsy, understanding about whether there is lymphovascular invasion or not. That's something you would not know, and then basing your decision whether to address the neck or not is a thing that you would have to look at. So are there any sort of indications for you to consider when you would address your neck and when you would not?
As far the study also mentioned, an NCCN criteria is also there. If DOI is less than 2 mm, we don't go for neck dissection.
Anything else that you would see?
Other than that, sir, like we can try for sentinel lymph node biopsy, but as such, omitting not neck dissection, I am not aware of.
Yes, that's a dilemma, especially as a surgeon you would face when you have a very superficial lesion and just a plaque sort of thing. But yes, your biopsy says it's an invasive malignancy. And then, if you have a patient, you've screened your neck, you've done your imaging, it's a N0 neck. And then if you have a patient who is going to be compliant for a follow-up, where you do a serial ultrasound neck, then probably you can consider with also a proper understanding that, when there is node presentation during follow-up, you have to, pick it up when it is really early stage. So that's something which is important.
Rakesh, what is the biggest flaw of this study?
So, the distribution of characteristics were not up to the mark, and as it was also retrospective.
That's fine. That all retrospective will have the inherent limitations. When you're looking at a study, you must know why that study has been done. Depth of invasion has always been done in tongue cancer. Okay, it has never been done in buccal mucosa. All the guidelines are in tongue cancer. Here, as you said correctly, you are trying to get indications to do or not do the neck dissection. So you have to have criteria which will tell you when you're operating the patient. You can't operate this, wait for the histopathology, then there will be molecular signature. There will be so many other factors that come in, and then go into the neck for the second time again. Okay, so that is the biggest flaw, that lymphovascular invasion, though it is maybe a predictor, we don't know whether it is, you get it only at histology. There is absolutely no point then going back again. You have to know at the point of this. And second, when you're reading papers, this is NCDB database. You must also make an effort when you're reading such papers, go to NCDB database flaws. What are the flaws in NCDB database? Can you point out any flaws? Can you point out any other article which has similar flaws? NCDB database is never complete. Okay, here they did not have information on various important criteria such as peridural invasion. Peridural invasion is coming in a big way for not only for local recurrence but also for metastasis to lymph node. Margin status was not known. Okay, so these are retrospective databases which do not have a lot of information, which can be what is called as confounding factors. If you had put in all these factors, maybe LVI would not have come significant. So there is a lot of missing data in NCDB database. There is a study on sarcoma of the limb where the study has shown that RT has no use, the adjuvant RT. So NCDB database has its flaws. So that is number one. And second, and most important, if you have to understand the treatment of tongue cancer and neck nodes, the biggest flaw of this study is that they have not understood why that N0 trial has been done. The N0 trial is not trying to tell you when to do or whether to do or not to do the neck. The N0 trial is telling you that if you don't do the neck, the survival is inferior. You have survival advantage if you do the neck. Okay, because what happens is, if you don't do the neck, the detection, detection of nodes, most of the nodes come in an inoperable stage. They grow below the sternomastoid, and the salvage rates are poor, or the salvage there's inferior survival. So that was looking at survival outcomes, not so much at factors predicting the lymph node metastasis. Here they are looking at factors predicting the lymph node metastasis. The only factor that is currently of any debate, as Girish correctly said, is a very small superficial tumor, less than probably 2 millimeters. And in this study, they've exactly excluded those patients. If you read the study properly, they've excluded patients with less than 2 millimeter tumors. And that is the subgroup that is probably today we want to avoid lymph node dissection. Rest, whether they go or not go, we don't know. We don't want to predict, but we know that if you don't do the neck in thicker tumors, more than 3 millimeters, the survival decreases. That's what the N0 paper told you. It didn't tell you what are the factors that necessarily go to the neck. So you must understand why the paper is done. This paper is of no use because it predicts factors. It has missed important factors, and it predicts factors which are not there during your surgical stage. Dr. Somashekar. Girish, any further question?
No,
Yeah, please.
I fully agree with this. I remember when I started my MCH, we read the Mishra et al. Paper who tried to extrapolate buccal mucosa depth of thickness in line with the same paper from MSKCC of the tongue and the floor mouth. That was a very big paper, most important thing in way back in 1999s. So we used to say, why do you want to look west? And the Indian paper we have from Mishra et al., which compared to 2.5, 5 and 6, and then the confounding factor like the grade, then perineural invasion and all sort of started mugging that. But I agree, but there's a way to forward in all other solid tumors is to tailor make the treatment based on the risk assessment. Now we know that all T2, N0, M0 are not same, all stage 2 are not same. Now there is an interplay of various other factor, and writing that right calculator to understand what is the weightage to be given is a way evolving science, but it is there everywhere, and we all know that the way the buccal mucosa or the GV cell curves or the RMT behaves than the tongue and the floor motor and the other is different, and this factor needs to be finalized. So that's why a paper like this needs to be analyzed by all of you.
Yeah, very important to know this paper because it tells you the flaws and it tells you the understanding of management of the N0 neck. It is not whether you can predict or no, it is whether if you don't operate and if there is occult metastasis which will grow, they come back in an inoperable stage, and that is what the N0 paper of Tata tells you. that there is survival advantage by doing therapeutic neck dissection. Only question it didn't answer is the less than 3 millimeters, but it's very, very difficult to measure. So as Girish said, those small superficial leukoplakias, small superficial tumors, which are erythroplakia which you excise, come back as well differentiated carcinomas. Maybe those are the ones you can get away with wide excision and observe the neck, because you have not done the neck that time. You probably don't have a diagnosis at that time, or even if you have a diagnosis, a very small superficial lesion. Those are the patients you can observe the neck. All patients, as per the current guidelines, you must, and majority of the guidelines, even the N0 study majority was tongue cancer, very few buccal cancer. See, in buccal, you can't have this depth because 1 centimeter will reach the skin. If you look at the anatomy of buccal cancers, you will reach the skin in a centimeter. So it's really not for buccal cancers. It's majority of these studies are for tongue and floor mouth cancers. Girish, any question?
Anything in the chat should we take first, the students?
Yes, please. Let's look at the chat box. Anybody wants to ask any question on the management of the N0 neck or factors predicting N0 neck? I think there were more questions for the NACT because that's an area of controversy. Here, the controversy seems to have settled a bit.
Yeah, especially after Dick Brewster's paper, I think there's hardly any controversy.
Yes. So the take-home message is do neck dissection for all. Worst pattern of invasion. Well, now there are various factors coming in. PNI, worst pattern of invasion. There may be, as you go ahead, there will be some molecular factors which will also come in. But all these are pathological factors, right? So these will not probably influence whether or not to do neck dissection. These will probably influence adjuvant therapy, right? So currently we have strict criteria for adjuvant therapy, such as positive margins, presence of nodes, presence of extranodal spread, so on and so forth. Whether these soft criteria of worst pattern of invasion, perineural invasion, these will then probably be incorporated in your decision making for adjuvant therapy more than management of the neck. Full thickness removal of skin in buccal cancer to remove buccinator is involved. Yes, Sandeep, there is no strict guideline for removal of skin, but as I always say, it is a combination of your clinical examination and your CT scan. If your CT scan shows buccinator involvement and on palpation you feel tumor on the skin, please excise the skin. Sometimes you will be overdoing it, but if you keep the skin, you will not get a 5 millimeter margin in the buccal mucosa. Of course, it depends on patient to patient. Some people have that sunken, no fat. There, obviously, it reaches the skin, but some people are fat and you will be able to get out. So it's a combination of clinical and CT scan. So you're right, buccinator is a guide for removal of the skin. If buccinator is involved or tumor is crossed, you must excise the skin, especially if you can. Don't press. If you can just feel tumor, you must excise the skin. Any other question? So, Caleb, what do you say N0? Currently, Caleb, N0 is set on the modality. We know ultrasound is operator dependent, so it is clinico-radiological. Now, whether what radiology you use, ultrasound is operator dependent. So, generally, for oral cancers, majority of the oral cancers, you will do a cross-sectional imaging, MRI for the tongue and CT scan for the buccal mucosas. So, that is what you will take clinico-radiological N0. 3 millimeters, very difficult to assess on table or in frozen section. So really, unless it's very superficial and thin, very difficult to assess 3 millimeters.
Question
Absolutely. And I want to tell the students, I had taken a class on TNM AJCC staging last month. So because there's a small handbook and there is a big big book which is brought by AJCC. It's very important for the student what Devendra told. Please don't get confused. See TNM in just clinical examination. No, investigations approved for that site are a part of extension of the clinical. Like for example, I'll tell you. Initially up to 2011 for cervical cancer only digital figure examination was the clinical TNM. Anything you do beyond that was a pathological. But now post 2011 we know that in that CT MR PET is added as an extension of clinical to interpret. Similarly, even in the breast, when you say it is clinically N0, ultrasound of axilla is a part of that. Same way what Devendra told, just don't take the tile examine. The way you examine, the way your teacher examine, the way a good examiner can pick up node. So extension of the investigation in the form of CT scan or MRI or ultrasound are a part of clinical staging. It's very, very important to understand what he told. So open the HSCC. In the clinical TNM, they have listed approved investigation which are component of clinical TNM for that subsite. And please read and make a note for all solid tumors. And in exam, frankly, you can say this is what we mean a clinical stage, not just a clinical examination. There is one more question, Devendra, I want you to answer. When to do the contralateral neck?
Yes,
This is
yes.
please answer that.
Yes, I was just coming to that. Very good question. It's an area of controversy. Now, currently, anything that approaches or crosses midline, we know that we have to address the opposite neck. 1A positive, we should operate the opposite neck. The controversy is a lateralized tongue lesion with or without ipsilateral nodes. Without ipsilateral nodes, you're safe to observe the opposite neck. Ipsilateral tongue. Ipsilateral tongue with positive nodes, we don't have great data, but the data is coming out that large nodal burden, presence of extracapsular spread, you must address the contralateral node. And Dr. Mishra has written more than 10 millimeter depth. Yes, there is a paper which looks at more than 10 millimeter. See, nowadays 10 millimeter, that's an old paper, but nowadays 10 millimeters automatically becomes T3, right? And most of these will have approached, if you have such a deep tumor, it would have approached the midline or crossed the midline. So in those cases, you must operate the opposite neck. Another information I'll give you for opposite neck, for lateralized tumors, T1 tumors, we do a supraomoid neck dissection. If 1 or 2 nodes are just a small node is positive, we don't do the opposite neck. But read the N0 paper carefully and ask your radiation oncologist. Most of the tongues, they will radiate bilaterally, bilateral opposing fields. That means in the oncologist's mind, we are thinking tongue with rich in lymphatics is draining bilaterally. We don't have an answer yet, but if you have to answer in the exams, 1A positivity, approaching crossing midline, and tumors with multiple ipsilateral nodes or gross extranodal spread, you must operate the opposite neck. The chances of contralateral failure are high. For a lateralized T1, T2 with no neck nodes or very small N1 disease, the contralateral failure is less than 5 to 10%. You may not address the contralateral neck. So I've given you indications of when to address the contralateral neck.
And that's a beautiful thing. There is something which I'll tell you because we had an honor of getting by JP Shah. There are two things. One is when to do a elective or selective or staging neck, when to convert it into a comprehensive neck dissection based on N0. So there are two books, please read. JP Shah has an atlas and a textbook, and Ramon Tiwari has a head and neck textbook. I had an honor, I worked with him for 5 years. Ramon Tiwari personally operated scrub with him. There are two things. On the unilateral, what constitutes a significant nodal burden? If you see JP Shah in an institute like US, UK, where patient has a very good follow-up, anything where you touch 10% and above is significant. But they put a caveat there. In a country like India, where there is hardly any follow-up, those patients, even this 10% failure is like 50% loss of overall survival in that group if they don't come for salvage treatment. So it's very important that opposite side, as Devendra told, chance is more. Ramon Tiwari textbook where they have put buccal mucosa, GB sulcus, alveolus, base tongue. What is the chance of ipsilateral more than 10, contralateral 5? Very beautifully written. Try to just read it. Things have changed because from that time to till now, HSCC TNM has modified itself. But you get an idea, and these concepts you need to understand and read the paper relevant to this.
I think it's 8:30. Any other questions or Girish, any closing comments?
There was a question on addressing the neck in a recurrent setting, contralateral neck in a recurrent setting. So that's a
right.
Yeah.
So again, no answer. There are no trials at this. But what happens in the recurrent setting, if you've done a tongue SOHD on one side and now you have a recurrence, the concept or the thinking is that there is a change in the pattern of lymphatic spread, right? If you've taken out the lymphatics on one side, the lymphatics are automatically going. They're going to go somewhere, right? Just like collateral. So they'll go into the opposite neck. We are looking at our opposite neck positivity, but generally today the dictum is that if there's a recurrence, then you must do the opposite neck. Again, no basis for this, no hardcore data here, but we are looking at the positivity of the opposite neck. And sometimes in recurrence, majority of the cases, you'll have to do a free flap and that open the neck. So because of the hypothesis that there is a change in the flow of lymphatics post neck dissection, in a recurrent setting, you must address the opposite neck. Of course, PET CT is also
fantastic. I think, yeah,
yes, Dr.
fantastic. I think that all good things has to come to an end. This actually shows how important this drug paper. I thought I had to first fix appointment with you, then confirm with the student which day to do it. It's a fantastic discussion. I thoroughly loved it. And students, you have no idea and the value of our great experts who have come and interpreted. It is their decades of knowledge, right from their student life to teacher's life to professor life to being a principal investigator. Impossible to get any amount of money, time, fame will not get audience with them. It is like getting high Supreme Court judges appointment running to $1 million per minute. Beautifully covered, Devendra and Girish. As I say, the purpose of the teacher is not to spoon feed. Students are not in first standard. We show you path, we show you direction. You have to walk it, and lot of ideas, concepts, interpretation has been given. Thank you very much. Heartfelt thanks to you, Devendra and Shetkar. As we always say, we can't give anything from DNB board. Only blessing to you and your family is what we can give from student and the board.
It's lovely to be here and discuss these papers. Looking forward for more such opportunities. Would love to be a part of it.
Yes, sir.
Thanks both of you, and
Thank you, sir.
over
Thanks
to you,
for the
Noni.
opportunity.
Thank you, sir.
Much trainees and faculty members for joining the session. Thank you.
Thank you.